So good morning, everyone. So we welcome you to the workshop today. So this will be the live ERCP US workshop,
Symptomatic.
and we will be doing say about 14 cases today.
Here we have a case of 43-year female patient with a history of jaundice and past history of left cholecystectomy in 18 July. After that, she has development of jaundice. So demonstration of benign biliary stricture by Dr. Amitabh sir. Sir, you are live.
Good morning, everyone. At the outset, I'll
Hello.
thank Dr. Malay for giving me this opportunity to demonstrate this case to everyone. So in this case, already it is a case of post-cholecystectomy stricture, and there has been ERCP twice. They've been able to put 2 stents, and still there are symptoms. And now what we'll do is, then in this case, we'll remove the already existing stents and then replace it with a metallic stent. Shoulder autonomy.
Good morning, everyone. I'm Dr. Varun Mehta from DMC. I'll be we'll be doing the patient together. Few questions, Dr. Amitabh, for you before we start with the procedure, since presently they are just relaxing the patient. So what are the symptoms which will make you think that you should be now placing a metal stent in a patient with a benign biliary stricture? I want to say, what forethoughts you would have?
So very symptomatic stricture which is resistant or which is not responding to already existing methods like plastic stents for a length of time. You can wait for a year. These are the indications where we can put the stent, or any patient who is probably not willing to come again and again, or wants a one-time solution, not ready for repeated ERCPs, repeated stent insertions, doesn't want to take a chance. Upfront
Okay.
metallic stent also can be offered.
Okay, so this patient has been having recurrent episodes of jaundice and maybe some 1 or 2 episodes of cholangitis as well. And the response to the plastic stents has not been adequate in the form of symptomatology. So that is the reason we are going ahead with the metal stent, which will be a fully covered metal stent in a patient with a benign biliary stricture.
So going in with the technique. So again, we hold the scope light, put it in the thing. And when you reach this part, which is the more delicate part, you can see here, yesterday there was a lot of discussion about whether to view, whether to go blind. So you can see, even if you want to go blind, you can see the things, just go behind this, and by itself, it slips in movement. You just have light pressure on the thing, don't exert much. You can see the mucosa right through here. And if you want to see the lumen, that can also be seen wee bit, but you don't need to if you're just scraping past. And this movement is important. You have to just wriggle the scope in your hand so that you don't go into any outpouching or any diverticular happening, or anywhere if it is a tortuous esophagus, anything like that. So this movement, which Dr. Malay also explained yesterday, is important to just wriggle past, or what he called as an earthworm movement is important, because then you don't strike anything. And ultimately, here somewhere you're reaching the stomach. On reaching the stomach, air you've been giving right through when you were in esophagus. So again, there was a discussion whether you should suck whatever the contents are. Yes, you should. If there is anything in the fundus, here it is all clean, which is good. And then follow the folds and you reach the pylorus. So once you reach the pylorus, the same setting sun sign, and you can just go inside. So once inside the bulb, that is where the movements will become important. So whatever comes at 6 o'clock position, as one person said, is the place where you'll be moving. So When you come here, you just give it a small twist, and then the movement has to be more gentle, like an US scope, and just let it ease out without causing any trauma, and you'll be there. And
Uh, For the beginners, I would like to add one thing here, Dr. Amit.
Yeah.
Like there has been always some teaching regarding locking of the scope when you enter from D1 into D2 and once you are actually shortening the scope.
right,
But we strongly feel that locking should not be done. You could actually hold the big wheel or the small wheel with the help of your support of a thumb
right,
rather than making a mechanical lock. Because sometimes mechanical lock makes the scope tip very rigid and hence can cause some damage. So we recommend that we should be using the thumb, yeah, which is more pliable and more elastic as a lock rather than using a mechanical lock.
I would fully agree with that, and I'm not a strong supporter of locking scope. As and when possible, if you
Yes.
could do it without lock,
Exactly.
wherever you are, with your body positioning, maneuvering, I think you can avoid the locks. It's only when the scope is slipping out
Yes.
again and again, you're losing position. That is where I would believe that you could probably lock, but then you should be aware that you've locked the thing, because even while pulling out, there have been times when you forget to unlock.
And
And
then
everything
causes a problem.
that causes
Exactly.
it. So that has happened with most of us at some point in time. If we go in history.
So this patient probably has already got 2 stents and the stents seem to be blocked because they are not draining bile.
So in the first, what ये कौन सा दिया? To दिया, बीच में से आ जाएगा. So we are using a rat tooth today. Yesterday we used a snare to remove the stent. So when you are pushing your accessories, again one caveat would be just keep everything relaxed, and your elevator will tell you if it is slightly elevated that your thing has reached the edge of the scope. So when it is reached there, be very gentle and try to catch it with the tip part of it.
Once you are enfaced with the papilla, your scope should be at around 60 centimeters. It should be straight on your fluoro machine. But to make it more straight, don't try to straighten it further because that might just cause the tip to actually hit the posterior wall and cause damage. So around 60 centimeters of the scope, fair enough straight position and fair. There's a worm which is sucking the blood. Can you see all? There's a
Yes, sir, we could
hookworm.
see.
Which is gone inside.
There's a
So probably
hookworm
a
which
hookworm.
is seen sucking the blood.
Yeah, live.
There's a blood in the cavity of the worm and you could actually see the, could you see the blood? Could you see the worm sucking the blood?
It is spitting the blood.
Yes.
That is.
You can see the movements of the worm also.
So probably it is, chewed more than it can swallow. Is that?
So there has been instances when there have been large sphincterotomies and you could actually see a scaries into the sphincterotomy site.
Open. So now we are using snare. So once you've opened the snare, just go as close as possible and try to catch it with the tip part. Yeah. Oh, open. Yeah, धीरे. Yeah. Okay.
So what is the technique, Dr. Amitabh, when you are pulling the scopes out? What is the technique? You try to straighten the scope to make it more amenable to be pulled out from the channel, or would you say that you need to remove the scope and take the stent out?
Nowadays, the channel diameter is enough actually for more, at least for 10 French stents to be pulled out comfortably.
Okay.
And what we do is the only trick here would be to keep it just close to the edge so that you don't need to kink it while taking it inside, and it can come as a single assembly. So once we have held it just from the tip, we make again the scope as straight as possible, and the elevator is just dropped, and now try to get it as a single assembly. So here we are losing. We'll go again, open, because this is the 10 French one, slightly bigger compared to the previous ones.
So while your assistant is closing your snare,
Yeah.
are you bringing the snare close towards the
I'm
stent?
pushing the snare inside. So bringing it close to it. So the distal part is the one which I have to control. The proximal, just closes because of him. Close karo or close karo.
Mucosa,
No,
थोड़ा
no,
सा
mucosa.
open, थोड़ा open करो, close karo. So we'll just wait for a second and then again try to pull this out.
Actually, if you could all focus, the stent is blocked. There are concretions in the stent. And this happens over a period of time when stent sometimes also starts behaving like a stone.
So we'll remove the entire assembly because this is slightly struck. So here again, we'll keep the scope straight and wriggle the stent out and then remove the entire assembly.
Ensure no locks.
Yeah, no locks,
Yes.
everything released. ये seal करिए.
So Amitabh, 10 French stent, I believe, should not be removed through the scope
Yes.
Right.
because 10 French stent may get maybe left inside the scope.
10 French actually, I believe would make something like 3.3 in total, if I'm not wrong. So with the 4.2, it's like a touch and go with slight changes which happen in the scope and in the biopsy thing. It becomes sometime tight, but yes, we can avoid doing that. It's not as easy on the scope, but at the same time, sometimes we do pull it out through the scope also.
If you use a Sugendra retriever, then you can remove it through the scope, not with a snare.
So again, with the same thing, you've reached the same place and now you'll be very gentle, just a wriggling movement and try to reach the same place without any trauma, without any resistance. So now again, we'll go inside with a sphincterotome just to see what is the position of the entire biliary tree, make a cholangiogram and then take it forward from there. Again, with the techniques of introducing anything, anywhere, if you're making a good loop, the things would go in easily because it is something like you're pushing something from below and it is going in onto the roof. So there has to be a gentle angle to the things.
Left, 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 left,
Yeah.
left, 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 left.
If you use a guide wire inside the stent also, you can remove it.
No, no. Left, 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 left. जहाँ से blood आ रहा है, जहाँ से blood आ रहा है,
ये होगा, डालिए.
no, जहाँ से blood आ रहा है. Ah, okay, perfect.
Yeah.
So you have to identify your sphincterotomy. You have to identify your sphincterotomy and then try to place the wire. We'll check the position of the wire on the fluoroscopy.
फ्लोरो इधर करना. I'm not able to see the fluoro.
थोड़ा कैमरा हटाना पड़ेगा.
Camera is coming on the way. Yeah. So the wire has gone through. Ah, contrast.
So do you expect that there were multiple stents, that there will be a stricture?
There's a structure which is which was seen in the previous cholangiogram. So how? Sure.
By chance, is the last cholangiogram picture available?
Yeah.
You have to push the sphincterotome up, up, up,
Yeah.
up,
Yeah. Done.
up, up, up.
दिखाओ.
Okay, so you are getting a cholangiogram, you're getting the right and the left hepatic ducts. I would like to recommend one thing, that once your wire has actually entered into the IHBR, only then you should be pushing the contrast.
दिखाओ.
So the mere presence of wire in the CBD should not prompt you to use a contrast. Once you are ensured that your wire is well anchored into the IHBR, you should be placing the contrast.
So the middle part of bile duct, do you think there is a stone or stricture?
Appears to be a stone possibly. We can, sir, Dr. Malay, we can actually,
We'll try to push some.
yes, push
contrast
more
with the-
contrast and then do it.
Yeah, डालिए, दिखाओ. लग रहा है.
I don't think this is a stone because what I remember, this is a bad structure. And it was after a lot of effort because we could go through in this case.
डालिए.
And that is why. So
The
have you
previous
shown the
ERCPs,
previous
they show a very
cholangiogram,
tight
no?
structure. So this picture is slightly different, but then obviously you put stents and there's been some modulation happening.
That is why. So it appeared as if it was a stone, but it is a bad structure.
So
What Ravi,
Dr.
doctor, you say?
Exactly, sir. Dr. Malay, how would you differentiate whether it is a stricture or a stone? A stone would also cause a filling defect. And how could you differentiate whether this is a stricture or a stone, Dr. Amit?
Here, if you see, going by the history and all.
I don't know. It still, I think the appearance, if it is going on, the wire is going on one side of the filling defect. That makes me think maybe some
So you do, so
stone is also there.
what do you think? Should we do a balloon sweep once?
If you do a sweeping, it may not come. Maybe a cholangioskopy will be a good idea to see inside.
Or second thing is, if you could move the position of the patient, you could put the patient in a slightly elevated head position and see if there's any movement of this filling defect. Then you could give some idea if it is a stone or a stricture. If
So the
The-
options are cholangioscopy. That is one thing. The second option is, why don't you try a balloon cholangiogram
exactly.
and see how the balloon comes back
So
in
we do a balloon thing.
when you come back
Right.
through this.
Right. Okay, change.
How
So we are exchanging the wire.
So
Because
maybe
this
the-
was.
So the
Thermo.
initial wire that we used was a fully negotiable yes, thermo wire, which is basically a water immersible wire. And that is basically used for negotiation. The second, now we are exchanging the wire because we'll be now using the accessories. This will be a slightly stiffer wire, which will be a nitinol wire, which comes by different names. It could be dream wire or it could be a navy glide.
दिखा रहे हैं.
So this will negotiate the structure and give us the strength for our accesses to be used.
So this is the
So
old
now
picture
this looks
of the
like a
last
structure.
ERCP, which clearly shows a structure here.
structure.
So this is the same
Yeah,
picture.
it's a kind of napkin kind of structure,
Yeah.
but the cholangiogram picture is slightly
Agreed.
different than this.
This time, yeah.
So Amit, you said you will always try a plastic stent before, if there is no response to plastic stent, then you choose a metal stent. Do you choose it as a primary modality? First time straight away metal stent.
I think
Nowadays,
that
I don't try plastic stent. I straight away, if I'm sure about the diagnosis, we leave a metal stent in the initial attempt only.
I think if affordability is not an issue, and but that is probably to me a better alternative than to subject the patient to repeated ERCP.
But ultimately, the cost will work out, in fact, more if you use
Almost
a
the same
plastic
ultimately.
stent.
That is only that there are EMIs and here it is a direct cost.
The only problem with the metal stent is that once the stick, it is naturally a fully covered metal stent, which we have to use, which is a removable stent. Partially covered stents have the chances of epithelialization, so they cannot be removed. So a fully covered metal stent has a chances of migration actually. So once the stricture dilates, it has the chances of a distal migration. That is the only issue that we tend to use first plastic stents and then maybe if it is a resistant stricture, because the guidelines also suggest that if the patient is not able to get adequate dilatation after 1 year or so of repeated ERCPs and multiple plastic stents, then it is reasonable to use a metal stent.
Loro. So we have introduced a balloon and we have gone above the.
Yeah, but then we use a double pigtail stent within the metal stent to prevent migration of the metal
That's
stent.
true, that's true, that's true.
Right. So double pigtail stent into that stent that will prevent migration is what the messages. Yeah,
The,
follow.
the current cholangiogram and the previous one,
They're
the
different.
balloon picture looks different. I think still we need to do a spyglass.
So we are very slowly taking this balloon down. And now it has reached where the stricture is.
Please show the C-arm picture in the bigger view of C-arm picture. Because
Siam,
bigger. Because,
Siam
yeah.
bada kare.
Siam,
Yeah.
Siam,
Okay,
increase
now
the
this
Siam.
is okay.
Yeah.
Now this is what we want to see, continuous imaging while you troll it down. And whether you
Continuous
can come down or not.
So fluoro on, please. Fluoro on.
So we've gone past that area.
So what
The
do you
balloon-
see in the middle?
Middle, it is still, the look is of a stone, whereas the previous one clearly says that it should be a structure which is now, filling probably by the sides. So there's some parts which have opened up, so it's giving a mixed type of impression.
Actually, if the audience would have appreciated, once we reach that area, the balloon suddenly
Snap.
slipped
Can
down.
you repeat the balloon cholangiogram
Yeah.
once more, please?
We'll do that. Collapse kara. So we have deflated it. Some sludge is coming out, but then that is something which will always happen in a system like this. Dikhao. Yeah. So again, we'll show it as a continuous thing.
Fluoro
Here
on.
is where
Now,
we have
this is
reached.
the area we want to see.
Yeah.
The
So if
balloon,
you
whether
see-
the waist of the balloon narrows or not, that is what we want to see.
Okay, we'll be very gentle and let's see if
Okay.
you, if
Now,
we
the
can.
only thing is, yes,
So
Yeah.
what we-
generally,
Getting
We
a review.
avoid-
Yes. there
see, it
is-
just snaps past.
Yes.
Sure. Dye डालिए यहाँ पे. Die. Sure. Yeah. So if you see now also you're doing a very gentle twisting and it's moving down. Show. Yeah. So what's the consensus now?
It's a structure.
so Ravi is insisting on a cholangioscopy. Now, what about filling the balloon with contrast?
Come again? Hello?
Like a banana and come out.
So Dr. Ravi said that this balloon will become like a banana and come out. So you don't know. So he says without a cholangioscopy, the only thing is the earlier ERCP showed something different. Earlier
different.
ERCP picture is very classical of a structure.
दिखाओ.
So yeah.
Sir,
So I think one doubt is amply clarified that this is a structure, not a stone. This is not a stone. We are amply sure there could be some
We are going
sludge
very
around the
slowly.
structure. Yes.
sir, do we have to suspect any malignancy? What is the time frame of between the two images? Because post-coli also sometimes a malignancy must have been missed. Is one concern, sir. Please elaborate.
So means we have Dr. Rohit Gupta with us. Rohit, would you like to do a cholangioscopy in this case?
Is it post-cholistic?
Post-cholistic.
And what is the time frame?
Dr. Rohit just joined. Can you show him the earlier picture? When
So do you want a cholangioscopy to be put up? Because then Dr. Varun could, start with the
okay,
cholangio.
Dr. Varun can do the cholangioscopy, please.
Actually,
So
so
I'm
the
re-
only problem is now the system has been filled with the contrast. Actually, for cholangioscopy, it is recommended that you should not be using, otherwise we can just wash it off, suction off the contrast and
Yeah.
then do a cholangioscopy.
Okay.
With the presence of a contrast in the system, cholangioscope is not the ideal thing to do actually.
See, can you show the earlier picture once more? The previous picture ERCP. Because
Cholangioscope ready
I
hai?
still am very sure. Just ask them whether it was a very, very tight, tough structure. And it was the balloon.
Actually, this sort of a stricture which is just below the hilum and away from the distal part of the CBD is best amenable for cholangioscopic examination. You could actually stabilize your scope in this part of the CBD, take a good sampling if required. And this sort of a stricture is, or even a stone at this site is one of the best for EHL also.
See, I would like to add one more thing now that I remember this case, because there are some pigtail stents in this case. So this case, there was pigtail stent. So there is a biliary leak. Patient had biliary peritonitis along with this bad stricture.
Okay, sir.
Collection was there, everything was
Okay.
there.
So the collection was there, and
Yeah.
this is a bad stricture, post cholecystectomy stricture. So now,
So again, in the light of new
I
evidence.
think with the history of cholecystectomy and this concentric narrowing, post-cholecystectomy stricture traumatic would be my first thing. Cholangioscope will, scopy will, I think, tell us what is it.
Dikhao.
If it would have been a stone infected in the mid CBD, it had allowed passage of three plastic stents.
because the time is getting up, because we have been following this case, Dr. Amitabh, I would request,
Okay.
I don't think this is a stone.
Yes,
The
sir.
patient has requested, he cannot come again and again. So
Right.
can you place a covered metal stent in him?
Sure.
Stent, go ahead with stent.
Sure.
And even if it is a small stone there, it will not harm. And also, when you did the ERCP today, I could see some sort of a leak outside the bile duct near the site of a stricture in earlier.
No, I don't think so. So I'm not too sure, but I think, I mean, What do you think?
The metal stent will anyways take care of that also.
Covered metal stent,
Yes.
removable.
Yes, sir.
So the
We'll take
patient
care of the
cannot come
small bile leak
again and
also if it is
again.
there.
So this is the reason that we will put in a covered metal stent. Yeah, now see this picture. Now previous, yeah. So this contrast is outside the scope. And this is possibly a leak
This
from the
is
side of the.
Dural contrast.
this could be in the lumen
Diurnal?
also.
Yes, this is the,
This is
appears to be
luminal.
diurnal
Dikhao,
contrast, sir.
Show again.
Okay, okay,
Show. Yeah, see, this is luminal.
diurnal. Okay.
That was luminal, yeah. Yeah. Not in the bile. Hi, Karu.
So what stent are you using, Dr. Amitabh?
It's a J Mitra stent, 8 centimeter stent, covered stent. Oh, just a second, just a second.
And show your wire.
Yeah. Acha. No, they brought a different stent. It is Medora Meditech. 8 centimeter stent.
So any types of covered stent, anybody is aware, Ravi? Any?
No, I mean, we have to use a fully covered stent because it's a benign disease. We need to remove it, that's for sure. There are different companies. Only thing is choosing the length. The problem with Boston is Boston stents, if they say 8 centimeter, it will 100% cross the hilum. So it has to be below the hilum. It should not obstruct the opposite duct wherever you. So 8 centimeter for Boston will be too long. So we have to deploy something like a 6 centimeter. But I don't know about 8 centimeter of this company.
So in a patient who's got a benign biliary stricture, due to causes other than cholecystectomy, the patient has got a gallbladder in situ, placing a fully covered metal stent across the cystic duct could lead on to severe consequences of cholecystitis. So in a patient who's got a gallbladder in situ, placing a fully covered metal stent could be counterproductive in a patient with a benign biliary stricture, or if at all, the anatomy has to be very clearly delineated and has to be placed below the insertion of the cystic duct.
Dr. Varun, can you ask the cameraman to adjust the camera to your face and shift the camera to some different location?
Camera.
So we are introducing the assembly of this covered metallic stent. And again, with everything relaxed, we let it reach the lower end of the scope. And you can keep your elevator slightly up to let you know that it has reached there. So here I've got the feeling that it's reached. And here it has come out.
Sometimes while passing the metal stand, I have had the tragedy that the wire has looped and
Hello?
come back.
Yeah, that is something which one has to
Anji.
be careful about, that you have to keep the wire
नहीं,
length
सब मंडे को मिलेगा,
as
मंडे के
minimum
बाद
as
मिलेगा।
possible between your accessories
हाँ।
that into the CBD. So here we just let it go in a looped manner. So from below, and then with slight movement of the scope, it goes inside. Again, let it loop, and with slight movement, it goes inside. Again, push it.
So what you're doing is when you're pushing it out, you're turning your body to
I'm
right.
turning to the left. When pushing, yeah, we are turning to the right to let it loop. When pushing it in, we're turning to the left, so automatically it's going inside. We slightly. So again, we are pushing it in, and then just turning to the left, and in the also we are taking the up control up to make that thing stiff and go inside. So again, we are watching for the lower end, which is the yellow end, and it will be visible once it comes out to the scope.
So you don't want to push it too much up.
We have to see the lower end once, and
Okay,
then
this
we'll
is the
make
last
one. Yeah.
retreatment area.
Yeah.
Once you,
This is-
yes,
If you can see, this is the yellow part which we were actually looking for, and it's reached. That means we can't push it any further, and we'll see where the upper end is. Show.
fluoro
So-
please.
So this looks okay to me. Now we can start the release slowly. Yeah. So as we release, we'll see the yellow end. Folder.
What is your endoscopic endpoint, Dr. Amitabh? What do you want to say when you say that you have to keep this yellow point into focus
So
always?
if the proximal end remains that place without shortening, it will block the left hepatic duct.
Come again.
No, the proximal end is much, if it has to shorten and come down below the hilum. Now it is blocking the left duct. The proximal end of
So,
the
it is an 8
upper
centimeter
end
thing, I
of
think.
the
So it has
upper
to be-
end of the metal
pull it
stand
bit
is
down,
now
pull it bit down,
across the hilum.
pull it.
You need
Actually,
to pull
this-
it down a bit.
Actually, this patient is, the height of the patient is just around maybe 4 feet 5.5 inches. So for her, we need to pull the stent
It
slightly
might
down.
shorten and come
Yes,
down,
yes,
but
yes.
if it
So
doesn't,
we'll
then it will
reassess
block
and
it.
see where we are.
It has to come down.
Show. Okay. You want it to
Yes.
come out a little.
If-
Okay,
I think yeah, now it has come in
Yes.
a okay position.
right. Wait.
Now it is in an okay position.
Yes, now it is
But
fine.
the advantage with this covered stent is that you can readjust the position even afterwards.
Yeah, we can. Sure.
So we need to push it a bit higher.
No, it's okay, Amitabh.
Yes.
The stricture is much.
The stricture is below it, definitely below.
Occasionally, we get a very proximal
yeah,
stricture.
yeah.
I think this is okay for me.
Yeah, I agree.
Because the upper end of the stent has to be above the stricture. It has to be around 2.5 centimeters above the stricture. And even if there's some foreshortening, then also.
Yeah, yeah. Yellow.
The yellow marker has always to be kept into the vision. You can see the last end of the stent, which is just close to the papilla. Pull a bit. Pull a
I
bit.
think there are a lot of stent available.
Can you see the stent opening up?
Yes.
Sure. So if we don't want to block, this part stays outside, because then And I think once it shortens a bit of it probably would compensate itself.
So you can
Want me
see
to-
adequate flow of bile from the stent.
Balloon then.
So I think we can shift to next case if Dr. says
Some-
that is ready with.
Sometimes these strictures will be very proximal. You won't be able to avoid the hilum. In those cases, it is advisable to put a plastic stent in the opposite duct and then maybe 10 French stent, and then in addition, deploy a metal stent in the right or left, whatever it is.
So we finish this case?
Thank you.
Thank
These
you.
post cholecystectomy strictures happen all over, sometimes it'll be very close to the hilum.
Can we just see the cholangiogram
Going by the-
floor of once more
Light के थोड़ा अंदर- I don't know कितनी block.
before we transfer? Can we see fluoro once more? Fluoro. Yeah,
There's no wasting now of the stent at the position of the stricture. So the stent appears to have started to open up. The proximal part is already opened up into the proximal CVD or the
And
CHD.
I think once it flares, the
Amitabh,
part which looks to be inside, that'll become lesser than what it is now. The flare would.
I'm a little worried. The upper end is too close to the hilum.
Yes,
Ravi?
yes. So that is the point. Actually, once it slightly shortens around 2 centimeters, then it is actually going to be at the mouth of the stricture.
So you think it will become even shorter after some
We
time?
think once the radial force takes over, the axial length would become a little lesser, maybe 1 to 1.5 centimeter, and it will reposition itself in the next day or two.
Okay, okay. You shift to other room, please.